How cool is that?
He's going to swallow some penicillin and see what happens.
Exactly. That's the plan for it.
That's good stuff. No, I thought about it this morning. I was like, I wonder if you get a cake and gifts, but hopefully maybe this afternoon.
Maybe. We'll see.
So this is going to be a little bit different than what we normally do in terms of the pharmacotherapy cases. As I kind of mentioned in the PowerPoint or in the recorded lecture, these are kind of cumulative based on what you've been taught and what you've seen in previous lectures. And kind of what stewardship ultimately means is we're trying to figure out what is the best thing to do for a patient, whether it's expand coverage, de-escalate coverage, totally change it. So you can feel free to agree, disagree. We'll talk tons of options. We'll have my input, Dr. Bland's input. We'll kind of go back and forth. Because the thing that I like most about this is there's not always necessarily one way to do something. There's multiple ways to do it. You may read something and interpret it a little bit different than I do and vice versa. So we'll kind of roll through these cases and talk through them as we go. If I can successfully, can't do it, navigate this. We got this nice little random number generator. So we're going to play. We're going to have fun. Since nobody would build me a random name generator, I have to use a random number
Dr.
generator.
Chastain, they are super excited here in Savannah. Let me just tell you.
There's been people in Albany that have done backflips. So, just do what? Cody gets all the questions. Okay. I don't know who Cody is, but Cody, Shabir recommended you get all the questions.
Wow. What a friend.
That's what I'm thinking too. It's the gift that keeps on giving.
Without friends, who needs enemies?
Exactly. Alright, let's get started. So the first patient is a 64-year-old female. She has AFib, she has diabetes, she has GERD, hypertension, hyperlipidemia. She had a right total knee arthroplasty in January of 2001. She comes in with a chief complaint of persistent shortness of breath, productive cough, chest discomfort. She has a chest x-ray with an early infiltrated right lung base. So right over here for everyone, this is her heart, and that's her spine. So right side, CT of her chest has a basilar infiltrate.
Thank you.
Height, weight, vital signs, any of the labs are listed. She does have an allergy to codeine, codeine, morphine, penicillin, which apparently causes significant diarrhea. Naproxen, she's admitted to the general medical floor with community-acquired pneumonia. She gets blood cultures and sputum cultures that are done, and she starts on zinc, meropenem, and voriconazole. So, first question is, do we agree with this or do we not agree with this? Group number 14.
We disagree because she doesn't qualify for outpatient pneumonia based on the CURB 65 score. Inpatient.
Okay, so what CURB score does she qualify for? Or what CURB score would you give her rather?
0.
A 0, sure. I can agree with that. The question becomes is she's already admitted though, right? So are we going to discharge her or are you going to keep her inpatient?
Discharge her.
Okay, I can see where you're going. So unfortunately, they don't want to discharge her; they want to keep her. So how does that change your plan?
So, this is Dr. Bland for Group 14. Remember, we want answers, right? The idea is to get answers going, get talking. That's what Dr. Chastain and I want. So don't be afraid to give an answer. We want to talk through it, okay? Because the idea, like you said, is to try to summarize what we've already talked about and kind of bring it together. Okay?
I don't think that voriconazole is indicated since it's an antifungal.
Okay, so no mori, antifungal. What are the, if you were to list a couple of the primary pathogens for community-acquired pneumonia, what would they be?
Strep pneumo,
Strep pneumo, good. Anything else?
the atypicals, Haemophilus, and Legionella.
Okay, so atypicals, and Haemophilus and Legionella, or atypicals including Haemophilus and Legionella?
Atypicals, colon, Haemophilus, and Legionella.
Okay. So atypicals are typically Legionella, Mycoplasma, and you'll hear it as Chlamydophila or Chlamydophila. Haemophilus is a gram-negative coccobacilli, so not necessarily an atypical. I agree with those. So in terms of coverage, would you leave her on vancomycin meropenem, or would you change her to voriconazole? Or excuse me, you said you'd stop with voriconazole. So would you leave her on vancomycin meropenem, or would you change it?
We would keep the bank if we were worried about MRSA, but since this is a community acquired, we don't think we need it.
Okay. So what about meropenem?
We honestly just want to switch it to levofloxacin.
Okay, that's perfectly fine. So how did you decide levofloxacin?
It's a respiratory fluoroquinolone.
Okay. Would Cipro work?
No.
So, first question that when things like this come up, or you're assessing someone's coverage, is are there guidelines that exist for community acquired pneumonia? If you know that they exist, they're on idsociety.org. That shows up terribly here because our projector is, I guess, dying. Hopefully you can see idsociety.org at the other campuses, but there are guidelines. They're a little old. Hopefully they'll be updated within the next couple of years, but you're right, ultimately. There's a couple different treatment recommendations that you can use. You can use a respiratory fluoroquinolone, or you can give something like a beta-lactam and a macrolide, or even potentially doxycycline or as an alternate to the macrolide. So you have tons of different options. It becomes how do you pick one and how do you decide one. So how did you decide on a respiratory fluoroquinolone compared to, say, a beta-lactam and a macrolide or doxycycline?
The patient has a fake penicillin allergy listed on their profile, so we're trying to appease them.
Okay, but you're not going to go explain to her that, hey, this penicillin allergy is not real. There's some data that does support if you avoid beta-lactams, if you avoid penicillin subsporins, there's actually worse outcomes in things like Staph aureus bacteremia, higher rates of C. diff, prolonged lupus stay, increased overall cost of hospitalization. So there are reasons to potentially go and educate her, not only for today, but also maybe for next week, next year, if she were to come in with something different. So I would encourage you that if you're faced with this fake penicillin allergy, to not just play into her hand, so to speak, but to maybe go talk with her prescriber, see if we can get some sort of information resolved, whether it's from her understanding, or even from a hospital perspective or a clinic perspective, whatever it may be. So if we were to compare one treatment versus the other and kind of exclude this patient from a fluoroquinolone perspective versus the beta-lactam plus a macrolide or doxycycline, are there any pros or cons to either of the two?
Hey, Daniel, you want to get another group involved?
Sure, absolutely.
Well, let's spread the wealth.
I like it.
I think I need some Ativan, though, in Savannah. They're like having a heart attack every time we do this. Random. Now, there we go, number one.
They don't like it. This thing's fun.
Yeah.
Number one. Lucky.
So the question was, what are the pros and cons to one regimen versus another group one? So what would help you decide between one of those two regimens?
Fluoroquinolone has more side effects for patients over age of 60, such as tendonitis and tendon rupture.
Okay, good. I agree. Much more potential. We'll talk about some of the side effects in just a little bit. and why fluoroquinolones may not be the best option overall. Anything else? Any other side effects that anyone can think of? Let's get this random number generator going. 25.
Yes. I've been waiting. All right, 25. What do you got? Other side effects of a quinolone that you might be worried about?
Prolonged QTC.
Prolonged QTC. We'll make Dr. Blank happy. How about this?
Yeah. Oh, there we go. Group 26. All right. Group 26, do you have anything else to add from a quinolone? So we got QTC. All right, real quick. QTC, why do you care about it? You guys are saying AFib, right? That's not true, okay? The different arrhythmia, right? The French arrhythmia, torsades, right? Right, so an important point is a lot of times you'll read an intermediate outcome. Lots of people have prolonged QTC. I can go right now to my floor. We had one yesterday, okay? But ultimately, you're worried about them going into a ventricular arrhythmia, known as torsades. But yeah, what else? So, you know, cardiac, tendonitis, tendon rupture, sure. What? Anything else? Be sure speaking to the mic through 26.
Altered mental status.
Altered mental status. Dr. Chastain, what do you think about that?
It's a stretch.
That's true. Yeah.
But you can make it work.
Yeah.
So
How about? Go ahead.
We bashed the quinolones for a minute. Are there any pros to a quinolone, or are there any pros to, or even cons to say, Rocephin-azithro or rocephin-doxy?
Group 21.
Group 21. We're having some discussion. There's a huddle currently going on.
A huddle?
A huddle.
A huddle?
Yeah, we're doing a small huddle of everybody that's in the whole entire class. One of these days I'm gonna figure out this camera, and then we're gonna have fun with it.
Yeah, I know, right?
Or are there pros to a fluoroquinolone? Is there a reason to use a fluoroquinolone against a beta-lactam macrolide, or is there a pro to using a beta-lactam macrolide, or a con? Any relevant information. Oh yeah, now I see the hub.
When you use a fluoroquinolone, you're just using one medication versus two, so that would be beneficial because you aren't overloading them.
Oh, wrong.
And it's once daily.
Once daily,
So is Rocephin.
and we're using
And is it
one drug instead of two. Oh yeah, now we're getting somewhere.
I love it, man. This is awesome.
I should make a YouTube channel.
We should. That's a great idea.
Viewership, a lot of money, a whole lot of money.
Get some Legos. All right, keep going.
So one drug versus two, I agree. Anybody else have anything? Group 25. Can't help it, that's the universe.
That is awesome.
One drug reduces cost.
One drug reduces cost. Okay. We'll give you that. All right, so we'll press forward. And we'll talk about some other things, and then we'll kind of come back to this. So there's multiple choices in terms of what would you pick and why. My preference would be a beta-lactam and a macrolide, or doxycycline. Again, a macrolide has the risk of QT prolongation as well. Azithro has kind of gotten beaten up in the past couple of years in terms of warnings with QT prolongation inducing patients in torsades. There was something a couple months back about higher rates of, what was it, malignancy relapse in long-term macrolide use. There was a warning that came out. But if we compare both regimens, fluoroquinolones did have a higher rate of C. diff. So that's certainly a downside. However, it's easier to transition a patient to an outpatient fluoroquinolone than it is to take Rocephin and Azithro and then send them outpatient. You can use a shorter duration of a macrolide, something like 3 to 5 days. It still gives you your whole entire coverage spectrum. So I think there's lots of options. Dr. Glenn, do you have a preference, one or the other?
So, yeah, for a lot of years, our preference was ceftriaxone plus a macrolide. Still is for me, simply because, as we've talked about in class, quinolones get used for so many disease states, just the sheer volume of prescriptions. Plus, like was brought up here in Savannah, the cost is a lot cheaper now for quinolone, even levofloxacin, because it's generic. So that has fed into more use of the drug. And so, some hospitals are going more towards a beta-lactam plus doxy, primarily because tetracyclines may have a protective effect on C. diff infection. And so, I actually like that regimen, but trying to get, I tell you, people get hooked on drugs, man, they get hooked on Z-Paks. And it's hard from a prescribing mentality to get away with that sometimes. So to try to change that mentality. But I would say probably most of the time we try to give the ceftriaxone macrolide. But Daniel, like you made a really good point, is that the macrolide only really needs to be there for 3 to 5 days. Atypicals are pretty easy to eradicate, and honestly, if it's not Legionella, there's a lot of question how much adding atypical coverage really means. Now, for your exam, whatever you were taught in CAP, I want you to stick with that, okay? But just know that, Legionella of all the atypicals is the one we worry about the most because it can kill a patient. And it's also the one that we will test for, as y'all learned about Legionella urinary antigens probably, that we test for. Daniel, that about what y'all do, or?
That is, we tend to go Rocephin Azithro. Every once in a while we'll get Rocephin Doxy in someone who's got a prolonged QT or a prolonged QTC. But things that are, to me, they're important to note is that there are tons of options with preferred beta-lactams. You can use anything from ampicillin to cefotaxime versus ceftriaxone. You can even use ertapenem, which I think is an awful choice because you're covering everything and then some for a community-acquired pneumonia. So trying to think about coverage perspective, we don't need to cover ESBL, E. coli in a community-acquired pneumonia. It just doesn't, there's no need for it. So yes, it's listed in the guidelines, but is it the best choice? Not always. So certainly something to think about kind of going forward and moving into practice.
So Daniel, I think that's a really good point you just made, and that is that you got to remember when guidelines are made, they will always be broad choices for most of these disease states because the guidelines just have to present if this drug has effectiveness for this disease state, then it's going to be listed. But that doesn't mean it's the best option. And that's why infectious disease, I know for you guys, is a very difficult topic. And Daniel and I both have talked about that, and it's because there's so many factors that go into selection. But yeah, it's just because it's there doesn't mean you have to use it.
I'll say that, so y'all learned Septarylin, Teflaro, and skin soft tissue infections, right? Yes. Dr. Glenn saying yes, maybe.
I didn't mention it a whole lot, just to be fair, but yes,
So-
and there's a reason I didn't mention it a whole lot.
Septarylin, I was always taught that it was kind of like vancomycin plus Rocephin in terms of coverage. It covers MRSA, it covers some lactose-fermenting gram-negative rods like E. coli, Proteus, Kleb. But it's FDA approved for community-acquired pneumonia. And so there's a hospital that I won't name that's within a couple hours of here that they email me all the time wanting to know, hey, should we add this drug to formulary? Should we use it here? And so they sent me an email and they're like, hey, we want to add Teflaro to our formulary for community-acquired pneumonia in every patient that gets admitted. Is that a good idea? And I was like, absolutely not. It's an awful idea because you're covering all these additional things that you don't need when you can get just the same efficacy with Rocephin, Azithro, Rocephin, Doxy, or even ampicillin, Azithro, ampicillin, Doxy. So there's tons of other options that are out there, and there's a bunch of drugs that are approved for community-acquired pneumonia because it's an easy indication to get. It's difficult to get FDA indications for a brain abscess. You can't walk outside and find 50 people that are just lined up ready for your clinical trial to say, hey, I have a brain abscess, please treat me for 6 weeks or 12 weeks with whatever you have. So it's a little bit more difficult to get these select indications, but just know that some of these drugs are kind of like an atomic bomb to your couple of pathogens that are the causative agents for community-acquired pneumonia. So I agree with what Dr. Bland said in terms of it becomes difficult to know what the best option is, and there's always more than one potentially best option. But knowing what those primary pathogens are certainly helps to figure out what's my best drug, what's my best choice, how much collateral damage am I causing by giving Teflaro to every single patient that comes to the ER with a community-acquired pneumonia.
And that's frightening that they asked you that.
They've sent some emails about Bavamere and Simdry for all UTIs as well. It's kind of interesting. So let's say we press forward in terms of we go with the levofloxacin, but your attending wants to give 250 a day of levofloxacin. So is that a good idea or not? Oh man, here it goes. 19.
Is that Albany or Augusta?
I don't know this.
And we just said no because the regimen we picked originally was just the levofloxacin 750 milligrams IV every 24 hours. So that was, and then discontinued other drugs.
So is 250 wrong?
Yes, it's too low.
Okay, so too low. So if we look at the guidelines, there is very explicit information in terms of what dosing the levofloxacin should be. It should be 750 a day or whatever the equivalent is. It's in the outpatient section, but that refers to wherever it's used throughout. It's important to understand that the reason for this is centered around its PK/PD and that its maximum concentration of the drug to MIC ratio is what is associated with its killing properties, its bactericidal properties, and so you want to optimize that. So it's very similar to when we talked in APP about once daily dosing aminoglycosides or high dose extended interval aminoglycosides, and then we give one big fat dose up front, has a really high peak, has greater killing ability, and then it tailors off throughout the end of the day, and you have some of those antibiotic effects with that as well. But it's the purpose of this is to show you that one dose, whatever it says, wherever you're looking, may not be the most optimal dose. So always trying to find out what is my best dose, how can I maximize this drug to ensure that I'm, one, getting it to the site of the infection, if it's pulmonary, if it's intra-ab, if it's on your skin, wherever it may be. But also you're making sure that it's most efficacious as well. So understanding that part, but then also understanding that levofloxacin is renally eliminated. So you may not be able to give 750 a day in every single patient. So knowing how to renally dose adjust medicines based on creatinine clearance with a lot of the older drugs, some of the newer FDA-approved antibiotics are moving towards GFR a little bit. So those are things that I think that are fairly easy for pharmacists to understand. You look at their creatinine clearance, you assess it, you determine, hey, is this the best dose? Are we close to where we should be? And then you can dose adjust. I know for us, at least in Albany, we have automatic protocols where you can dose adjust up, dose adjust down, depending on what renal function is. A friend of mine works at a little smaller hospital, and he has to call physicians every time he wants to change a dose based on renal function. So again, depending on where you go, depending on what you do, those are things that you're going to encounter going forward. Anything to add, Dr. Blaine?
Yeah, we actually have a case ongoing in the hospital, just to make a point, on an exam or something that's going to be very clear. We're not going to try to trick you and things like that. But
I'm not, from my perspective, creatinine clearance and these dose adjustments are available in references. The guidelines are available in references. my goal is for you to understand, or our goal is for you to understand the basics of these things and to understand what the appropriate regimens for something like community-acquired pneumonia is. Not necessarily, this lady has a creatinine clearance of 12. So I have to know exactly what her dose should be and know that it's levofloxacin. That's not the ultimate goal. You can Google dose adjustments for levofloxacin and the packaging will come up. You can use up to date, although it hurts my heart to use up to date. It's available, it's there, and that information is readily there for you. If you were to attempt to memorize and learn every single renal dose adjustment for every antibiotic, I would be impressed. But I don't have enough marbles in my brain for that.
Yeah, me either.
Dr. Chastain,
Yes.
could you use Moxie for a patient with poor renal function?
So can I flip the question and ask, why would you use Moxie for someone who had poor renal function? That's an excellent question.
Because
I like it.
it's not
Very good
renally cleared.
It's not renally clearable. How does it clear if it's not renally cleared?
The liver.
Thank you, sister.
Okay. Exactly. So it's hepatically cleared. Moxie would be a fantastic choice. I think that would work perfectly. It's once a day, 400 milligrams once a day, IV or VO. We don't have it on formulary. We only have Cipro and Levo on formulary. So again, that also plays into account what you can and what you can't get. In terms of coverage between Moxie versus Levo versus Cipro. So why isn't Cipro listed up here to be used for community-acquired pneumonia? Does anybody know?
It doesn't have
Oh, there's
good
a lot.
coverage against strep pneumo.
Doesn't have good coverage against strep pneumo. I agree. One of the questions that I
Happening,
was,
Dr. Chastain, they're learning.
I love
It's
it.
half, do you feel it?
There's a lot of light bulbs. I can see it.
Our room's getting brighter, it's kind of strange.
Ours is too, but I'm not sure if it's the sun. I'm just playing. So one of the questions that I get constantly is, can I use Cipro for any pulmonary infection? It's not a respiratory fluoroquinolone, so therefore it doesn't get to the lungs. Is that true or false?
False.
Good. So, I agree 100%. Cipro penetrates the lungs. You can use it for pulmonary infections, but again, going back to what the original point was, is that it doesn't have good strep pneumo coverage. Excellent. Nice work.
Thank you.
Yeah, the point I was gonna make is sometimes in practice, there are borderline calls that you have to make. I had a patient recently, with levofloxacin was actually being used for nosocomial pneumonia, and their creatinine clearance was like 45. And I was on the fence about adjusting, and they came back with culture with Pseudomonas, and it was one of the few choices we had. So that's a rare case. In class, the kind of what Dr. Chastain's saying, it'll be clear what to do. But sometimes, just so you know, in practice, if you have a borderline case, especially if you think that person's renal function is only temporarily, down, and you think it's going to go up, you may elect to stick with the full dose.
Risk versus benefit.
Love it. Why do ID, baby?
Okay.
So, this is something that I battle a whole lot in terms of fluoroquinolone use. So, one of the questions that was on the cases talked about FDA warnings, and we have alternative options for this. We've kind of already hit on some of these alternative options and what some of the pros versus the cons would be. But usually, from what I can remember, most of the time the FDA sends 1 or 2 warnings about a drug, and they kind of let it go. There's recalls and black box warnings that get added, of course, but to me it's very interesting that we've had 7 or 6 now FDA safety warnings about fluoroquinolones that just keep getting pushed out there over and over and over again. But yet, there was a paper that came out not too terribly long ago that I believe looked at fluoroquinolone use from 2011 to 2016 and showed there was really no decrease in fluoroquinolone use despite all of these warnings. So community providers haven't really changed their practice in terms of not using fluoroquinolones. So I think it's something to note and to be aware of, especially whether you work inpatient or outpatient or in the ER, to have alternative recommendations for someone if they're trying to use a fluoroquinolone and maybe there's something better or something that's equivalent to it, to potentially avoid some of these side effects and some of these issues.
Yeah, I think an important perspective on this is the patients, and just understand that your patients are going to read a lot of news, and I think patients, honestly, Dr. Chastain, will help us with this long term because because of all these warnings, there's becoming a lot more patient concern over this drug class in general. So, that may actually help us in the long term. But you're right. I mean, they're just so easy to use, and that's what I think drives a lot of the usage.
1-800 bad drug.
Oh yeah, I remember that commercial. It was Dewey, Cheatham, and Howe, right? Sorry, that's not bad. But anyway.
I don't know. I don't get it.
I'll take you.
Okay, you have to wait. All right, so with that being said, kind of going back to some of the same image earlier in terms of what the recommendations are, but then not only the appropriate drug, but also the appropriate duration. For some reason in the U.S., people love 7, 14, 21, 28, 42, so forth and so on. But very seldom do you, very seldom do you ever see 5 weeks, which I think is very interesting. They use 4 weeks, they use 6 weeks, every once in a while you can get a 21-day course or something. But 5 weeks tends to not happen. I guess we skipped over 35. But with community-acquired pneumonia, when you have a patient who, say they improve very quickly, very rapidly within the first 48 to 72 hours, then you can give them 5 days of therapy. Now, with that being said, it's important to understand that azithromycin has an extremely long half-life. And so if you were to give 3 days of 500 milligrams, that's going to last for at least 5 days, if not closer to 7. So being aware that they don't need 5 days of 500 milligrams of azithromycin outside of Legionella, and understanding that it's still working despite not taking these pills, versus giving them a fluoroquinolone or giving them oral cephalosporin or even augmentin as an oral option, potentially transitioning them to outpatient. Those would be daily, and those would last for the entire 5-day or maybe even out to 7 days. The other thing that becomes important is what they receive inpatient counts towards what they're going to get outpatient. We have prescribers who, maybe can't do math, but let's say we're going to give somebody 14 days for a bloodstream infection, whatever it may be, and they got 8 days inpatient. Well, then they tack on their 14 days of discharge. So that 8 counted. Exactly understanding why people believe that the ones you get inpatient don't count. Maybe they don't work. Any thoughts or comments?
Yeah, Dr. Chastain, remember that? So Dr. Chastain and I are working on our manuscript together. And remember that article that we found? 70% of antibiotic use related to a hospitalization occurs after they leave the hospital, right? So that goes to the point that most of the antibiotic days of therapy are when they leave. And a lot of that is not relevant. It's inappropriate because, like you said, they don't count, or they just kind of go. A lot of times I'm a big believer that the computer systems are the problem, and that they have a default number listed, and it doesn't make the person think about, oh, I really should look to see how many total days of therapy they had and subtract what they need from what they've already received. So just simple things like that, behavior modification, I think. And some of that data, it has been published, that just changing simple things like that can decrease overall use.
Good points. All right. So case number 2.
Wait a minute, I got that case 1, that penicillin allergy.
Oh, you're going to talk about
No, I just want to say one thing. Fake news. All right, keep going. Diarrhea. You see that all the time. National Penicillin Allergy Day. I've already had 2 of my friends. I just had another one, Dr. Chastain. They want to get tested.
Popular guy. I thought,
I don't know.
we had anaphylaxis-induced diarrhea.
Now, that would be interesting. I call that post-ictal, but anyway.
Okay, I got another municipality for you on this one.
Oh, yeah. All over.
So this is a 54-year-old male. He has hypertension, hyperlipidemia, diabetes, anemia, metastatic colorectal cancer, got Folfox and Avastin, which y'all get a whole bunch of all that shortly. Multiple surgeries, chemo, but admitted with sepsis, UTI symptoms, and some abdominal pain. You see all of his vitals listed, allergies, penicillin rash all over. He's also allergic to sulfa. His urine culture is growing gram-negative rods, and his blood cultures are growing gram-negative rods as well. He's febrile, he's a little bit hypotensive, but he's on vancomycin and levofloxacin on admission. So, do we agree or do we disagree with this, and why? Group number 2. I like how it shows you how it goes into the numbers. I think that adds a little bit more fun to it.
I don't know that they agree here. Man, look at this regimen. That's kind of a common regimen, right? Do y'all use that in Albany? You see that a lot?
Fortunately, we don't see the levofloxacin. Levofloxacin kind of went by the wayside. We use a lot of vancomycin though.
Yeah, a lot of Bosin. We get that too.
We do not agree with the treatment.
Okay. So the second part of that question was why?
It's too broad.
Okay. So if you were to change it or make it less broad, how would you do that?
We would discontinue the Vanc and the Zosyn.
You vancomycin. So why?
So they have gram-negative rods in their urine and blood. So we don't, yeah.
Go ahead.
So we don't need the Vanc. And since it's a UTI, we don't need double pseudomonas coverage either.
Is it just a UTI?
Never mind, it's also sepsis. Yeah.
Hey, did he just drop the mic?
I think so.
Or he passed out from anaphylaxis, not due to penicillin. All right.
Due to diarrhea-induced anaphylaxis. Or anaphylaxis-induced diarrhea. One of the two.
You're conflating things. Thank you. That's everybody's new favorite word.
So, anybody else? Let's get some more. We'll get some more insight.
Yeah, I like it.
Group number 8.
Oh, yeah. This is a good time to share that 8 days is enough therapy for most hospital-acquired and ventilator-associated pneumonia. Right? 8 versus 15 days, y'all go over that?
8 versus 15.
Right? Remember that study? I always try to figure out why they did 8 and 15.
Because it's Europe.
Exactly. That's all you need to know. All right. What do you think, Group 8?
So the patient just has gram-negative rods, so they don't need to be covered for gram-positives, so you don't need vancomycin. You could potentially discontinue Piptazo and just treat with Ceftriaxone.
So DC levofloxacin as well?
Yeah, to get rid of all 3.
Okay, so go down to something like Ceftriaxone. So does Ceftriaxone cover all the gram-negative rods?
No.
And
Which
so
one does it leave out? What's the major gram-negative it doesn't cover?
Pseudomonas.
Hey!
Good.
You think they're at risk?
Potentially.
Oh, I think it's more than potentially. Daniel, you think she's at risk, this patient?
I think he could be. He's got a nice hemoc history.
Yeah, he does.
Gets a little Folfox, Avastin.
Sure.
So let's see. Anybody else have any additional moments?
I like that Graham thing, man, that was nice.
Group 11. Are they nice? Good stuff.
Yeah, it looks pretty. Unless it's you, then it's in your blood.
The ones that always work like that. I like the ones where our micro lab will retract the gram-negative rod and call it a gram-positive rod, but don't addend the note, they just totally change it.
Correct, that's, they try to hide.
So then you look like a moron.
Then you look like an idiot, exactly. That's happened to me, so. What group are we on, Dan?
Group 11.
All right, group 11.
Sorry, Ms. Fortier, you will be shortly.
Sounds like we're on hold.
I'm sorry, I didn't mean it that way.
Oh, no offense. It's hard to offend me. Yeah. It just reminded me of like when you're on hold with Delta.
Get some whole music going. Or the Jeopardy.
Yeah, Jeopardy. Need some music.
All right, so we're back.
I like it.
Okay, so we seem to be a little divided. So half of us will decide to, we would recommend piptazone, and the other half of our group is trying to stick with levofloxacin.
Okay. Split down the middle.
I don't know what
So she's still febrile. She's still gonna have a fit. Or she will. Eventually we'll get this right.
She added an entire
and
syllable to keywords.
It's set. So what's the point of double coverage against gram-negative rods? Does anybody?
Would it be if the patient has like risk for pseudomonas?
So of the drugs that are up there, how many of those drugs cover
The Levo. And, and the piptazone too.
Good. So we have 2 drugs that cover pseudomonas. We have 2 drugs that cover gram-negative rods. Vanc, gram-positive, I think we can unanimously agree, hey, let's get rid of it. That's probably not our issue. But the purpose of double covering something is to ensure that you're increasing your odds of having activity against something, or having activity against that organism, because there is resistance that's out there. And that's kind of where the problem lies, especially in someone who has an extensive past medical history, who's been exposed to the healthcare system over and over and over again. Maybe his normal flora is not an easily treated E. coli. Maybe his normal flora is now Pseudomonas, or is a multi-drug resistant E. coli. You can walk around and be colonized with multi-drug resistant organisms, just like you can walk around and be colonized with a very susceptible E. coli. So you have to take into account those things. Once you know your isolate, and once you know your susceptibility, then you can get rid of double coverage. You can drop one for the other, or you can stop both and narrow it down much more. And I think most of the time, I would say in clinical practice, if this patient was already started on Vanc, Zosyn, and levofloxacin, and let's say they're in the ICU and you're going to go talk to the critical care physician, they're going to be a little nervous to get rid of Vanc and Zosyn or Vanc and levofloxacin. They'll probably want to hang on to at least both of those because of that double coverage piece. And then once you start to know a little bit more information in terms of susceptibility versus what the isolate is, then you can probably start to back off a little bit more. What do you think, Dr. Blaine?
Yeah, I rounded with the ICU team for 11 years or so. I was very fortunate. I worked with some pretty progressive practitioners that, as soon as the gram-negative rods came back, especially being in the urine and the blood, they would have been pretty quick to stop the Vanc. But in all likelihood, they would have definitely left the piptazone, the levofloxacin alone until they had definitive susceptibilities.
It's definitely a balance, and trying to win a little bit of, I guess, a little bit of the overall battle to eventually, hopefully, win the war, so to speak. In terms of getting one stop today, and then we can get the next one stop tomorrow, and kind of approaching it that way instead of, hey, I want to scrap everything they have, all 3 drugs, and then pick this one. But if it's an IV consult for infectious diseases, then it's much easier to get things done because they understand what bugs and drugs and what to cover. But in terms of bloodstream infections, the one thing that I want to make sure that everybody walking out of here and going forward understands is that bloodstream infections are always secondary to something else. And so the goal of you working up this patient who has a bloodstream infection is, what is that secondary to? And it becomes important to understand what normal flora is and typically where these organisms are isolated and where these organisms are located. And typically, most of the time, gram-negative organisms tend to be below the diaphragm to your groin. So the first place that I always think about in terms of, hey, I have a patient with gram-negative rods in blood, the first 2 places that I think of are GI and GU. And so is that my primary source? If that's not, then I'll start searching other places. But those are typically the ones that I go to first in terms of, we have to resolve this source, we have to resolve the source of the infection before we can ever take care of the overall bloodstream infection.
Dr. Chastain,
Yes.
I have a question. So I know that he doesn't say he has like an anaphylactic reaction to penicillin, but it does say he has a rash all over. So is it still okay to use the pip-tazo, or would you do something more like cefepime?
Oh, man. That's a good day. Today's a good day.
So they're already on pip-tazo, right? And they reported this penicillin allergy. So you could do a couple things. You could go physically look at him and see if he has a rash. You could also go ask more questions about his rash. But one of the important things to understand is that a lot of these allergies tend to wane over time, whether it's IgE mediated or not. Maybe it was a rash when he was a child and he got ampicillin. And so one of the things that you'll come to learn or come to understand is that Epstein-Barr virus, EBV, and the administration of ampicillin tends to result in a higher rate of rashes than just Epstein-Barr virus alone.
I have a question.
Okay.
So on the test, there was somebody that had a penicillin allergy, and it had been like 20 years. Do you think that's long enough for it to wane?
If on the test, on the test.
As in the previous one.
I can answer that question because I wrote it. Yeah, 20 years is plenty. In fact, if it's IgE mediated, there's some data that 5 years, even if it's anaphylaxis, 5 years is enough for that to wear off. In fact, when we look at assessing those allergies, our protocol is 10 years for anaphylaxis. Then you could possibly, evaluate skin test that person. But for a rash, I had a couple of questions where there was an allergy on there, so I'd have to know which one it was. But one question was a very mild reaction like 20 years ago to penicillin. And in that patient, the answer wasn't cephalosporin. And the reason for that is the cross-reactivity in mild rashes is very low, less than 5%. In fact, in recent data, it's more like 2%. So to answer the question that was brought up by, I don't know where they were, could you do cefepime instead? Yeah, if I would have been involved in this case immediately and I'd have seen that allergy history, I think that would have been reasonable. But like Dr. Chastain's saying, if they're on pip-tazo and they're on dose 5 or 6 and they don't have a rash anywhere, then that kind of answers the question for you, and guys, that happens. Sometimes allergy history is not well documented across everywhere in the chart. Maybe they know it, but maybe it didn't get done when they came in. Why? Because these patients are septic and they're not exactly mentally with it. So you can't get a good history. maybe they arrive via EMS, and there's not a family member with them. And so it's hard to get that history. And so even though we know most of them are bogus, until we actually have objective information to rule it out, sometimes we just have to assume. Now this one, they just went on and went through it, and they survived their, we call it the trial of life. You know? Sorry, Dan, I don't mean to take over there.
No, that's good stuff. And so the other piece of that is always go back and look at you have, or I would say most hospitals, I don't know if it's universal or not, have electronic medical records that date back to some point in time. So you can always go back in their chart and look to see what they've received in the past. If they have a cephalosporin allergy, we know cefazolin is a huge pre-op antibiotic that gets used all over the place. So they document the cephalosporin allergy, but have they ever received the cephalosporin? So that's a way to potentially go look at it. In our EMR, we can look at probably 60 or 65% of the fill histories, depending on what pharmacy they use and what insurance they have. So maybe they report this penicillin allergy in the chart, but they're getting augmented every other week. The other thing in terms of clarifying allergies is you understand what penicillins versus cephalosporins versus all the drug classes are. You understand these bigger, fancier names, but maybe the patient doesn't. So asking, have you ever taken amoxicillin, clavulanic acid versus Augmentin versus amoxicillin versus Keflex or cephalexin? So whatever it is, try to use multiple different ways to get the answer, to ascertain the answer, and making sure that they understand what you're asking. Are you allergic to penicillin versus, hey, I see you're allergic to penicillin. What happened when you took it? Or how many years ago has it been? Was it yesterday? Was it 6 months ago? Was it 50 years ago? Who knows what it was and how it all worked out. So being aware that patients don't understand on the same level that you do, and making sure that you tailor those questions appropriately, I think becomes really important in trying to clarify some of these allergies.
Yeah, that's a great point. I remember skin testing a person probably a year ago, and I thought we had done heavy screening on them, talked to them. It's almost like interrogation. And I'll never forget in the middle of the skin test, she's like, oh, you asked about this drug earlier? And I said, yeah, amoxicillin, clavulanic. I said, have you ever taken Augmentin? She's like, oh yeah, I've taken that one. Right? And, and I'm just about to, I was finishing the skin test, and I'm like, well, I know what the result on this is going to be, right? Negative. Because she had taken it already. So there's a lot of data coming out that just by assessing the allergies in depth, especially as a pharmacist, you guys ever seen the movie Taken? Right? What does he say in that movie? He says, I have a very special set of skills, right? That's what you have when it comes to allergy assessment more than most other healthcare providers. And so by using that, you can clarify probably close to half of, quote, labeled allergies without doing anything further, just by doing investigation and talking to the patient.
And don't be afraid to go talk to the patient.
Yeah, please. I've got a question here in Savannah, Dr. Chesney.
Okay.
When do you know to use double anti-pseudomodal coverage? Like, is it disease state specific or is it patient specific?
That's a good
Now
question.
we're getting somewhere.
So, I don't think there's necessarily one universal answer. I think it goes back to a little bit of both patient specific and disease state specific. If you have a patient that's septic or in septic shock, on pressors, on a vent, then I think it's worth it in that situation because you have no idea what you're trying to cover. You're trying to cover a little bit of everything potentially. But in terms of going back to thinking about this patient who has an extensive past medical history, has been in and out of the hospital, in and out of clinics, whatever it may be, that's someone that I would be more likely to double cover against Pseudomonas in than, say, a 42-year-old farmer who's never seen a physician in 30 years or never been to the hospital in 30 years and has zero past medical history.
Yeah, that's a very hard question. Now, in pneumonia, there's a little bit more clear recommendation. Oh, my mic's gone. We can hear you. Can you hear me? It's a little light, but anyway. Well, all I was going to say is in pneumonia, is pretty clear. There's several things that everyone agrees upon, and that is presentation and septic shock, and also receipt of IV antibiotics within the last 90 days. Those are things that I agree with, and I think most everybody agree with. What's happened in the last 5 to 10 years, there used to be this term called HCAP, healthcare associated pneumonia, and all it did was make us use more double amp coverage on a lot of patients that didn't need it. So I would say in the last 3 or 4 years, we've seen a lot less double coverage. But in this type of thing, anybody with a recent history of cancer that's being treated, septic presentation, has seen IV antibiotics in the last 90 days, those are really high risk to me. And I think that would be reasonable.
The other thing that I was going to say is maybe someone who's colonized with Pseudomonas and whether it was truly grown from an active infection versus if we swab the top of their wound, or maybe they have an extensive history of soaking their foot. Maybe they have this big diabetic foot ulcer. They've been soaking their foot in water over and over and over again, tap water. And Pseudomonas being a waterborne pathogen becomes a bigger issue. So I think it's very patient specific, but also disease state specific as well, in terms of who needs double coverage or when is double coverage warranted. So a couple other points to kind of briefly mention about this, because the next piece of this is something that I want to spend a little bit of time on. But there are things that can help you. So antibiograms, certain disease states, whether it be UTIs or intra-ab. We'll mention rates of quinolone resistance in the 20 to 25% range, and if it's above that, then maybe an empiric fluoroquinolone is not your best option, and to use something different. But everybody would love to have 100% susceptibility on an antibiogram. An antibiogram is ultimately you've taken all the isolates that you've grown, or the large bulk of the isolates that you've grown in the past year, and you have a cumulative susceptibility against whatever bug and drug that may be. And so maybe it's 85% of all E. coli are susceptible to Rocephin. And so are you comfortable with 85% in someone who's septic or in septic shock? And so is that somewhere that you would change their coverage and maybe be a little bit more broad or add something else to it to hopefully bump up that 85% to say closer to 90 or 95%? But if we were trying to shoot for 100% on every single patient, then I think we would cause a lot more damage, and not only to the patient in and of themselves because of some of the drugs we would have to use, but also to the overall susceptibility of the whole entire ecosystem and environment. So certainly risk versus benefit. But then there are also some things that are helpful in terms of a rapid diagnostic test. Maybe it provides you some data off of whole blood, meaning the isolate doesn't necessarily have to grow before you can at least identify what type of organism it is. Gram stains are helpful, but knowing that it's an E. coli versus a Pseudomonas is certainly more helpful than just, hey, it's a gram-negative rod. So there are lots of things to come. Rapid diagnostics, I believe you get from Dr. Bland. You already got rapid diagnostics. Oh yeah. Oh, well then I'm
last year. So can you hear me now?
We can hear you.
Okay, great. Yeah, it's been super helpful for us. I know Dr. Chesty, I don't think you guys have a lot of the rapid diagnostics
We
yet.
don't.
But myself and a UGA grad, Allison Porter, we have a paper that's currently being edited that really showed how we were able to optimize therapy. Because, and I know this is hard for y'all to visualize because you've probably never been in a microbiology lab. Just as a reminder, what typically happens is when these blood cultures are drawn from the patient in the ER or wherever they're at when their septic episode presents, those bottles typically go down to the micro lab into a machine. And that machine is trying to detect initial growth of an organism. That takes somewhere around 12 to 24, maybe as long as 60 hours on the organism. A patient like this, most of the time, the machine will detect growth in about 12 to 24 hours. And so at that point, you can put it on one of these rapid diagnostic platforms and identify the organism within about, depending on the device, somewhere around an hour to 2 hours. Now, but like Dr. Chesney said, you don't have susceptibilities with one exception. There's one machine called Accelerate that will provide susceptibilities 7 hours after identification. So this is the future. It's very exciting to be able to identify these pathogens quicker. And I think 5 years from now, most platforms are going to have susceptibility coupled with the actual identification.
So, in the essence of time, to make sure that we can get through the other ones, so you get E. coli back. So we were worried about Pseudomonas up front, potentially, given this patient's past medical history, but we get E. coli. And so we've maybe scanned their abdomen. Did we find something that's urinary? Did we find an abscess? And is there a need to consult surgery to either laparoscopically do it or maybe an open abdomen? Because at the end of the day, the goal is to have source control. So the question that I have now, and something that I think is extremely important, not only for today, but going forward, is how do we pick a drug? We know, we'll say we left this patient on pip-tazo and levofloxacin. So are we good with those, or do we need to change them? Group 17.
It's gram-negative. E. coli. E. coli.
It is susceptible.
Oh, yeah, that's true. I don't know. I picked. I don't know. I know.
Like a sample school.
Just say it. Just say it.
It's group 17 here.
We're here. We're debating.
Debate.
Oh, there is no debate. I talked about this.
What?
What is this Nick thing?
You always want to drop the mic. Low numbers are good.
What do you mean?
So
But
this
it's
is
not
just, this is
debatable.
question 3.
No, it's question
But
two.
it's fair. That's really the question. You know, one of the medical residents asked me one day, it's the lowest mid, but it's best, right? And it took me about 5 minutes to realize exactly what they were talking about.
Yeah, the first time I got called about it, well, I'll bring it up later. I think it comes up later. What do y'all think? 50-50.
So we're just answering question 2, right?
Just question 2, unless you want to answer the rest of them.
So I would say change it from the regimen they're on, because just choose a more narrow thing like cefazolin or something, since it's susceptible.
Do the numbers matter though?
What do you say?
What did they say?
What?
Do the numbers matter? So like Cipro's a 1, Cefazolin a 2, so shouldn't Cipro be better?
I don't know.
We haven't been
I like group 6. We'll get some other opinions, other options.
Seems like they're not going.
There's lots of options.
I think you should go by like spectrum first and then MIC.
Oops. Spectrum and then MIC. So what is that?
Yeah, explain that a little bit. I'm a little confused. But we'll pick
Like, levofloxacin is really broad, but you could pick a Ceph with a low MIC.
So, Danny, you want to take this one or me?
It doesn't matter. Either way, whatever you want to do.
I'll take it since I caught it. No, you don't look at the numbers. The numbers mean for 95% of what you're going to interpret, they don't mean anything. What you need to focus on is the S, the I, and the R. Because 2 governing bodies are out there, the FDA and something called CLSI. Okay, we didn't talk a ton about this in class, but I did give you exceptions, right? So for instance, with a vancomycin MIC of 2, even though that is susceptible for MRSA, there have been some reports of increased clinical failures. Remember, these are being measured where? In the lab, right? So they're in vitro. Even though it's from the patient, they're being they're being tested down there outside the body. So what I would tell you is your spectrum of activity point is actually well taken in the sense that we want the narrowest agent. We'll talk about that a little bit more in these cases. But for the numbers, honestly, at my institution, I wanted the numbers blocked. I didn't want them reported unless it was a specific circumstance, like I said, with vancomycin, 2 MIC, 2 MRSA, because in those circumstances, there are data to support that even though there's an S, if the patient's not doing well, you may want to change to something. Okay? But overall, don't look at Gen of 4 and look at Tobra of 4 and then look at some other drug that's 2 and think you can't compare between the different drugs. Because the FDA and CLSI, the governing bodies, they make those breakpoint determinations only on that drug. So it's either susceptible, it's intermediate, or it's resistant. As a reminder, what does that mean practically for, the family medicine physician that's treating a UTI or treating this at a community hospital? Well, by the FDA standards, what that S means for that drug is that when you treat that patient for that infection with that antibiotic at FDA-approved doses, you should get a good clinical outcome. Does that make sense? Dr. Chastain, you want to add anything? I'm sure I left some holes in that coverage.
No, that's good. So the only...
Come on, that's funny, holes in coverage. Oh, man.
That's good. The only other point that I think becomes worthwhile to note, or 2 points rather, if you were always going to go by the lowest number, Bactrim would always win. It's a fraction. 2 over 38 is much lower than 1 and 2 and all these other values. So certainly, the lower the number is not always the best. The other thing is that these susceptibilities are based on blood concentrations of these antibiotics. So if you have a brain abscess that you go in, you actually get some tissue from, and they are able to isolate an organism, they're able to culture it, they're able to run a susceptibility, the numbers are going to be the exact same, whether it's in the brain, whether it's in the blood, whether it's in the urine, whether it's in the lungs. And so we know daptomycin doesn't penetrate the lungs. It binds the pulmonary surfactant, can't be used for pneumonias. But yet, the MRSA that you grow from your patient's lungs will still be susceptible to daptomycin in the lab. Now, some labs won't report daptomycin in lung infections because they're aware that daptomycin doesn't work in the lungs, and so they'll take it away and retract it. But you'll find from time to time that daptomycin becomes reported out on MRSA that grows in somebody, or out of somebody's sputum, or out of somebody's bronchial wash, or whatever it may be. So understanding, do these drugs penetrate that site, is also something that you have to take into account of, is this a decent idea? Is this a decent choice? So there's a whole wealth of information that's listed within this table in terms of being able to understand and kind of identify. But kind of going back to what Dr. Bland mentioned was that really and truly the biggest focus should be on SIR and understanding, does your drug get to that site? If the drug gets there, great. Let's press forward with it. Because then we can also start to throw in things like IV versus PO. Can we get away with an oral option? But are you going to send a patient home on a 5 times a day drug or a 1 time a day drug? Something that's extremely difficult to administer or something that's a little bit easier. So there's a lot of things to consider kind of going forward. And even in this patient, you can say anything from cefazolin, which in somebody with normal renal function would be 3 times a day. You could say ceftriaxone, which is once a day. Or you could say maybe even a fluoroquinolone, which could be given orally. And again, either being once or twice a day, levo versus cipro respectively. So I think there's options, and you have tons of options. It ultimately becomes what's the best option, and how can we justify that? So to complicate things just a little bit, this nice young man is going to leave AMA, and AMA means against medical advice, and doesn't want to pick, doesn't want IV antibiotics. So can we give an oral regimen? And if so, what oral regimen would we give?
Do you all know AMA, Against Medical Advice? Also the American Medical Association.
True. I thought this thing likes number 11.
Can I ask a question about question 2?
Sure.
I'm wondering if this person was found to be legitimately allergic to penicillin, what do you think would be the best choice or choices?
So let's say he was, and so what would you pick?
I put down as Trianon, but I'm guessing maybe that's too broad.
So the first question I would have is if he was to truly be penicillin allergic, what would his true allergy be? Would it be anaphylaxis, or would it be this rash? And so I think there's a different level of how you choose in that situation. I think Aspirin would be not my first option. Aspirin certainly can be used in somebody who has anaphylaxis to Vailactam. But again, you're talking about something that's 3 times a day. And we're going to need to treat this for a handful of days going forward. So maybe a 3-time-a-day antibiotic may not be the best ideal in someone who's going to go home. So if I had someone who was truly penicillin allergic and I was afraid to try cephalosporin, then I think that I would do something like Cipro or Levo. Dr. Bland, do you agree or disagree?
Yeah, I agree. What was the reaction reported again? Was it just rash?
Right, so this patient was just a rash.
Yeah. So, a lot of it would depend on what kind of history I could give the patient. That rash is probably was documented in the chart. But yeah, Astrianam is probably the most expensive way to treat a gram-negative infection, not named Abicaz. Okay. It's highly expensive over all other agents. And so I can tell you that wherever you go on rotation, if you recommend Astrianam, most pharmacists are not going to like that recommendation on rotation because it costs so much money. So I think if I can clarify that penicillin allergy was really, it might be real, but it's not anaphylaxis, and it's not serum sickness or something like that, then you could easily go to cefazolin or ceftriaxone. But I will tell you in practice what most likely would happen if I can't clarify that, they're probably going to get on Cipro or levofloxacin, because it does have the advantage in that the bioavailability is much higher than beta-lactams, and it kind of prepares that person for the duration of their therapy.
Group 11, I hope you're paying attention. Dr. Williams, softball.
Yeah.
So, can we give this patient an oral antibiotic? And so, what could we give them?
Yeah, we were saying that, obviously it's not ideal to have him leave in the middle of treatment, but if he's just, absolutely adamant he's going to leave, we could switch to an oral antibiotic, like we said, Cipro or Levo could work. And on maybe even penicillin if we're not that worried about the allergy anymore.
Yeah, so this is Dr. Bland again. So what about an oral beta-lactam? Let's say the penicillin allergy is not there. Go back to the susceptibility, Dr. Chastain, if you don't mind. So what about, say, ceftriaxone? That has a PO dosage form. Would that be okay? Let's say they had an allergy to fluoroquinoline. That happens. What would be your concern, if any, with something like ceftriaxone? Or even augmentin? For purposes of, this is discussion sometimes, but Ansel Backham susceptibility, can you definitively say that Augmentin, which is Amoxicillin, is susceptible in most circumstances? Yes, not the other way around. But what would you think about Augmentin or say Ceftriaxone? Group 11.
I think either are appropriate options, but I would choose Amsulbactam due to cost.
Okay, so Amsulbactam's IV only.
Oh.
So what would be, what's kind of Amsulbactam's PO equivalent?
Augmentin.
Yeah. So would you have any concerns with Augmentin or Ceftriaxone specifically? Summarize this patient for me. They have E. coli where?
In the blood.
And?
Urine.
Right. So going back to what Dr. Cheston was talking about source, right? So if this were your mother, and I was going to give her an oral antibiotic, this got personal, right? And that's what I tried to tell y'all from day one, right? These are not just cases on the screen, these are people. If I were going to give your mother Augmentin, would you have any concern? And if you did, what would it be? What would you want to know about Augmentin?
I will also throw out that every patient that I ever give you is a modification of a real patient that I pulled from the chart.
Same here. I'm not mad at you, I'm just getting serious for a minute because this is a serious question. How about any other group? What are you concerned about? I'll just throw it out to the whole class.
Let's throw money out the window as well.
Bioavailability?
Yes. How well is this drug absorbed? Because at the end of the day, this is a bloodstream infection, right? This is not just a urinary tract infection. This is not a skin soft tissue infection where the, abscess was drained and they don't have any other signs and symptoms of infection. This was a sick patient who, oh, by the way, has a cancer, right? And so their immune system at baseline is, even if the white count is normal, how well they send off infection. Because remember, antibiotics don't cure infection. Your immune system cures infection. Antibiotics are just helpers. So for that reason, I would tell you, me personally, and Dr. Chastain, you may feel differently, for that reason, I think a quinolone would be ideal. But there's a drawback to that, right? The drawback is this is a high-risk patient for other things that we can talk about if we want to, that make quinolones not the best option. But at the end of the day, the most important part of antimicrobial stewardship is treating the infection. You worry about adverse effects, but at the end of the day, you got to treat the infection appropriately. Dr. Chastain, do you have any other thoughts?
I agree. Bioavailability and making sure that it, in this situation, doesn't concentrate well enough in the blood. And so we were going to talk a little bit about IBPO, but just to kind of show you some of these numbers in terms of what we're talking about bioavailability. Levofloxacin is 99%. So that's why we can go 1-to-1 from the ratio perspective. Cipro is up to 85%. Depends on dosage form, depends on patient age. But again, with Cipro, we do 1 to 1.25. So if it's 400 milligrams IV, then it would be 500 milligrams oral. But beta-lactams in general are typically less than 75% or up to 75% rather. So yes, they're absorbed, but in most situations, they're not absorbed enough to have high enough drug concentration in the blood to effectively treat a bloodstream infection. And so why do I care about a bloodstream infection? What's the biggest problem or multiple problems that could occur is that maybe it sticks to your heart valves. And if it sticks to your heart valves, then we're talking about endocarditis, maybe it the vegetation flicks off and seeds their kidneys, seeds their lungs, seeds their brain. There's a whole lot of additional collateral damage later on down the road that could happen if this isn't effectively treated appropriately up front. And so while, go ahead.
Sorry, Dan. No, man, I'm sorry, I apologize. Go ahead, I'll go at the end.
So while this patient may not be the perfect one to give an oral option at this exact moment, there are times that you have to kind of modify your plan a little bit to facilitate the patient to do whatever the heck they want to do at the end of the day. There are people who, if it's day 3 and it doesn't matter what's going on, they decide, hey, I've been here long enough, I'm ready to check out a hotel Phoebe, and we're going to go home. It happens. It happens a whole lot more than you would think. Or maybe a nurse was mean to them, or maybe they didn't like the physician. There's all sorts of stuff that happens that people just decide, hey, it's my time. I'm getting out of here. I don't care what you do for me. I'm going.
Especially substance abusers. The classic one we have here in Savannah, we get a lot of it, is alcohol abuse and alcohol withdrawal. So by day 3, they're starting to withdraw. They can care less about whatever's going on. They're just wanting to know, how can I get my next beer? So it does. It happens here a lot too.
Gill's patient's like alcohol. Ours like that.
Well, we have a lot of cocaine too. But yeah, for sure. The only thing I was going to say, somebody had asked earlier about what about Moxie for that CAP patient. Okay. You wouldn't use Moxie here because Moxie doesn't get in the urine, right? Not in good concentration. But another point I wanted to bring up is, let's say this was a CAP patient that had strep pneumobacteremia. If that happens, okay, one thing you got to consider is, remember when somebody's getting switched to PO, they're likely going to go home on it, right? Well, what happens if they can't afford it? They're going to be back, right? So Moxie is typically a lot more expensive than Levo or Cipro. We wouldn't use it in this case, okay, for a lot of reasons. But just keep that in mind that cost definitely comes into play when you start talking about discharge medication, whether that's IV or PO. Daniel, do y'all have patients that stay at the hotel Phoebe because they can't afford whatever therapy it is, IV or PO, and so they hang around the hospital waiting to get a DVT or something else?
Ours didn't hang out at Starbucks with their IV pole. Or either they'll get discharged to, it's called Phoebe North, and it's kind of our long-term hospital.
Gotcha.
Questions? All right, case number 3. Case number 3 is almost hallmark Albany, Georgia.
Oh wait, this is Savannah too.
58-year-old female, tons of past medical history to include anything from Hep C, depression, seizures, but transferred to your hospital with a bacteremia secondary to a left arm AV graft. So they've already told you where this is coming from, so that's extremely important in terms of overall management. No allergies, blood culture, gram-positive cocci for 3 straight days out of both sets. Labs are otherwise not too terrible. Creatinine other than a 5.4, but again, they have that AV graft because they're on hemodialysis, and they have end-stage renal disease. And so vascular surgery sees them and puts them on vancomycin. So what are we going to do? Is vancomycin the most appropriate regimen for this patient with gram-positive cocci in blood who is a hemodialysis patient? Group 24.
All right, group 24.
So we said since it's a gram-positive cocci in clusters, that's usually Staph aureus. So we were going to go ahead and assume that it might be MRSA. So we would keep the patient on bank now, but I guess if we found out it was
really MRSA, we would de-escalate to Bactrim, Clinda, or Doxy. We weren't really sure.
Okay. So a couple things. So gram-positive cocci in clusters, I agree 100% in terms of staph. So it could be Staph aureus, whether it be MSSA or MRSA, or it could be what's called coagulase negative staph. So meaning things like Staph epidermidis, Staph hemolyticus, Staph saprophyticus even for that matter, so things that aren't as virulent as, say, a Staphylococcus aureus. There is one coag-negative staph that is extremely virulent. It's called Staph lugdunensis. It has similar virulence to, say, Staph aureus, and so we tend to treat it a little bit more aggressively than we will a Staph epidermidis, which oftentimes is nothing more than contamination in your blood cultures. But going back to the last case in terms of drugs that concentrate well enough in the blood, drugs that are most effective for bacteremia, Bactrim, doxycycline, and clindamycin are probably not my first choice for an MRSA or even an MSSA in blood. They tend to have a little bit less success than, say, a vancomycin, daptomycin, cefazolin, naxolin for that matter. Dr. Glenn?
Yeah, no, I was just going to say, those drugs you mentioned, Summer, classically you think of those drugs for only skin soft tissue infections. So if you have that situation, not bacteremia necessarily, those are great options. Sorting through those we kind of talked about when I taught skin soft tissue. But yeah, I mean, gram-positive cocci in the blood, you're going to stick initially for sure with IV agents. So yeah, and that's a lot of your all's learning is, and I know there's a lot to learn, is figuring out where certain drugs fit in, and kind of those older, Clinda, Doxy, Mino, Cycline, Bactrim are going to be more your uncomplicated MRSA type infections like skin structure.
And that's also something excellent to think about in terms of those drugs will be reported out on your susceptibility result. Regardless of where your site is, it'll say doxycycline, it'll say Clinda, it'll say minocycline, Bactrim, whatever it may be. But going back to, yes, those work in the test tube, yes, they work in the lab, yes, it works against this organism, but it doesn't work at enough drug concentration in my patient, wherever that source or wherever that site may be. So, a couple things with this patient. So again, always thinking bloodstream secondary to something else. And so we have a left arm AV graft. Going back to this previous slide, so AV graft meaning that there's some sort of synthetic material connecting the artery to the vein, and so they'll get hemodialysis through their AV graft. You can see an actual picture here, and so you can always feel a thrill and a bruit in terms of the blood flow, and hear it kind of going through, hear and feel it going through that graft. And so with that synthetic material, again, it becomes difficult for us to actually penetrate with a biofilm that eventually forms on that synthetic material, and so that's why one of the reasons why vascular surgery is consulted in terms of trying to get it out. But we have this patient on Vanc and Zosyn, and so do we still need both Vanc and Zosyn? The short answer here is Zosyn's probably not necessary. But we're worried about staph, so do we need to add some sort of anti-staphylococcal penicillin or cephalosporin to Vanc? And in most situations, there's really not enough data to support using an anti-staph penicillin and cephalosporin on top of Vanc while you're waiting on your susceptibility results. We can leave them on Vanc, we can see what happens, see what grows, see what we isolate, and then we can go on from there. The other important point to make is Staph aureus bacteremia. Staph aureus is one of the most common causes of endocarditis, right? So we have to think about, is this patient at risk for endocarditis? And so I know that y'all had endocarditis previously. So I know this one, I remember this one, so outside of the rapid diagnostic piece. So in terms of workup, we can do a transthoracic echocardiogram, so on your chest wall. But again, you may miss some things in terms of this patient being 89 kilograms versus if they're 220 kilograms. Maybe your view of your heart's not going to be as good. Maybe they have some sort of pulmonary disease, so we're not going to get as clean of a picture, as clear of a picture of their heart valves compared to, say, if we do a transesophageal echocardiogram, to where we kind of go behind the heart and look at the valves a little bit better and get a little bit better picture. So TTE versus TEE, you cannot definitively rule out endocarditis on a TTE, but most situations, I've had very few where cardiology will do a transesophageal echocardiogram first. Most of the time they'll always do a transthoracic first, and then we'll advance to the transesophageal. Those few cases have been when somebody's already in the OR for something else and they're going to be under anesthesia, or maybe they're intubated in the unit. So things to think about, but the most important piece of this is to repeat blood cultures. We have to show their blood is sterile before we start this count in terms of what treatment should be and how long it should be. So always repeating blood cultures. That also goes back to maybe we thought that this guy's source, or this lady's source rather, was her AV graft. Maybe that was what her primary source became, or what her primary source was, but maybe she had endocarditis and it's seeded somewhere else, and maybe we now have a new primary source, so to speak. And so repeating those blood cultures will allow you to know, did we achieve source control or not? Dr. Blaine, anything to add?
Yeah, the only thing I would add is regarding the, again, just kind of a pearl and a point about rapid diagnostic testing. Remember, most of the systems don't tell you susceptibilities, right? Which is not very helpful for gram-negative infections. However, you know, if this is Staph aureus, our rapid diagnostics will tell us that, and it also identifies the gene that is, you know, identifies MRSA versus MSSA. So this patient, on the second bullet point there, do you add the anti-staph penicillin or cefazolin? We would never do that, because once this starts growing and we get the gram stain, within an hour we know if the MEC-A gene, which identifies MRSA, is present or not. And so if we're MEC-A gene positive, we know it's MRSA, we treat appropriately. If it's MEC-A gene negative, then we automatically de-escalate potentially, and most likelihood to those others. So just know that even though it's rapid diagnostics and it doesn't give you susceptibilities, we do identify certain genes, especially with gram-positives, that allow us to make therapy changes even before official susceptibility testing come back, because those genes are highly sensitive and specific for susceptibilities.
So in this situation, we do get susceptibilities, and it is Staph aureus. And so vascular surgery came, achieved source control, they took out the graft, blood cultures became negative. So is this MSSA or MRSA? Because I have difficulty telling sometimes.
I'm going to cry if they don't get this.
Group number 10.
It's MSSA because it's susceptible to oxacillin.
Fantastic. It's good stuff.
Oh man, good. I didn't want to cry in front of everybody.
So one of the questions that I get frequently is, how can it be MSSA if it's penicillin resistant? And so understanding that penicillin ACE, so a very specific enzyme that will hydrolyze penicillins, is what makes a penicillin susceptible Staph aureus turn into a penicillin resistant MSSA. And so if you look at ampicillin versus ampicillin sulbactam, so that's kind of your telltale sign in terms of I'm giving sulbactam, which is a beta-lactamase inhibitor. It locks up that penicillinase and therefore allows my ampicillin to continue working. So just because it's penicillin resistant or ampicillin resistant does not mean that it automatically becomes methicillin resistant. Methicillin, oxacillin, napcillin are all resistant to that initial penicillinase. And so sometimes you'll hear them called penicillinase resistant penicillins, or anti-staphylococcal penicillins is also another common term that is used. So we're still on Vanc. Is Vanc an appropriate option in this patient? Should we keep Vanc going? Because it is susceptible after all. Group number one.
And number one again. So group one, are we keeping them on Vanc?
No, we would de-escalate.
To what?
Napcillin or oxacillin.
Okay, so napcillin, oxacillin. So I can agree with that. For time-intensive purposes, because there's one more case after this, and I think it hammers into a pretty good point. So in terms of a dialysis patient, there are a couple things to consider. So I agree, napcillin and oxacillin are fantastic options in terms of MSSA bacteremia. They work fantastically. Things to consider in terms of napcillin and oxacillin are either it's going to be 2 grams every 4 hours, and so you're going to make a whole lot of nurses mad, have them go through every 4 hours and give an antibiotic, or you can do 12 grams as a continuous infusion over 24 hours. It's not renally dose adjusted, so same dose regardless, but they tend to carry a lot of sodium content. So maybe in a dialysis patient, a ton of sodium is not the best idea. Most of the time they'll go in 1 liter of normal saline, and I'm sure Dr. Hawkins has taught you over and over and over again about normal saline and the negative effects of it. Cefazolin in normal renal function is 2 grams every 8 hours. In a dialysis patient, we can give it after hemodialysis. So hemodialysis is typically 3 times a week, Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. And so in this patient, if it was Monday, Wednesday, Friday, they could get it immediately after dialysis. So they don't have to get an additional IV line put in. It can be done with their dialysis access. Some people argue and say, oh, Vanc's a great option because we know that they're not going to eliminate a whole bunch of it. They can get it with dialysis. But Vanc is actually inferior to beta-lactams, including napcillin, oxacillin, cefazolin against MSSA. So you actually would give them a worse option and increase their risk of things like VRE for the long term in a dialysis patient. So I would say Vanc, not a good option here. Daptomycin is also another option. There's some new data and some emerging data in terms of using it after dialysis because typically it's given every 48 hours. But there may be a way to use it only after dialysis. But again, daptomycin is an expensive drug. It's better than Vanc, and it's comparable to, say, napcillin, oxacillin, or cefazolin in terms of MSSA. But the biggest question is do we need to give them something like daptomycin, or could we get away with a napcillin, oxacillin, or a cefazolin? Oral options is no, just across the board. Again, it'll tell you that it's susceptible to tetracyclines. It'll tell you that it's susceptible to Bactrim. But one of the things, and there's always caveats to all of these things. There's caveats to every single thing across the board. Zymox is a great drug. It's 100% bioavailable, and so if you had to push somebody in a corner and they weren't going to take anything from an IV perspective, then maybe you could argue and say, hey, this would be an option. But at the end of the day, when you think Staph aureus bacteremia, you think IV antibiotics for the entire duration. In almost all situations, Staph aureus bacteremia is 4 weeks from the first negative. So, from my perspective, remember Staph aureus bacteremia, remember IV antibiotics, and repeating their blood filters.
Yeah, Daniel, I agree with that. We talked briefly in class about the POET study that just came out. If we had more time, you and I could talk about that with them. But bottom line is that, in my opinion, oral therapy, we're just not there yet. And especially with a Staph aureus bacteremia, if this were endocarditis, they're still going to get IV therapy for the duration.
And maybe with that, it becomes one day that we do half and half, say half IV and half oral versus 100% oral. And I agree with Dr. Glenn in terms of we need additional data, we need additional studies that have been done. But at least for now, Staph aureus, you think 4 weeks, there's select few patients that can be eligible for 2. But most of the time it's going to be 4 weeks and they're going to be IV the whole entire time. Very, very, very often I get asked about Levelin. So, hey, my Staph aureus is susceptible to Levelin. That should be okay, right? And again, the short answer is no. There's cases that date all the way back to the early 90s and case reports and also some in vitro stuff that talk about on-therapy resistance to fluoroquinolones, meaning that, yes, it's susceptible in that split moment in the test tube, but you start your patient on Levelin or Cipro even for that matter, and they do okay for the first 24, 48 hours, but then the staph becomes smarter than that drug and develops resistance, and they get sick all over again and come back. The other piece of this is rifampin. So yes, rifampin's susceptible, rifampin's IV. Rifampin's fun because it turns all of your bodily fluids reddish-orange. Who doesn't want that in hot South Georgia heat? So rifampin should be thought of as a synergistic drug, especially in the setting of biofilms with Staph aureus. So hardware, when you hear hardware, we think rifampin. But if we give it by itself for, say, a Staph aureus bloodstream infection, then on-therapy resistance will develop and they will eventually fail. So it needs to be with something else. But in this patient who's had their source removed, who doesn't really have any hardware, rifampin would be necessary. Any questions, any other comments, Dr. Boyd?
I think we'll move on to the last case.
10-minute burn through. So 48-year-old male who is mechanically ventilated and a mechanically ventilated dependent patient from a nursing home. He had a traumatic brain injury, trach, PEG, prostate cancer, hypertension, diabetes, recurrent UTIs, transferred because of sepsis, with leukocytosis and a cold left foot without pulses, has decubitus ulcers, and I show you a nice image over here of various different stages of decubitus ulcers. But it appears uninfected. Chest x-ray is really insignificant. You look at his labs, his white blood cell count is 11.8, so technically it's over whatever your upper limit of normal of 10 versus 10.5 is. But all in all, looks okay. So they admit him to the unit because he's on a vent. Gets IV fluids, gets vancomycin, gets some wound care, gets put on the vent. Again, can't really come off. And some pain management as well. So, do we like or do we dislike this option? Group number 6. Man, the chances of this is in my low.
It's either low or high. Not a lot of middle numbers today.
I'm going to do it next time. Miracle salad. That's got to be a good one.
We all think group 6.
We disagree. We wanted to stop the vancomycin and the meropenem.
So stop everything altogether?
Yes, stop everything and then initiate levofloxacin 750 IV QD plus tobramycin 500 IV QD plus as treated.
I'm sorry?
Plus as treated.
Okay, so levo, tobra, astridium. So can I ask why?
There's a list of Pseudomonas. It's inpatient ICU, and it was in the PowerPoint.
Okay, so inpatient ICU, in terms of, but what are we treating? What do you think your indication would be for this?
She thought it was ventilator required pneumonia.
Okay, so could it be ventilator required pneumonia? So again, looking back at the chest x-ray, so there's no acute pulmonary infiltrates, no signs of any respiratory failure whatsoever. He's dependent upon a mechanical ventilator, so he's never going to come off, or seemingly potentially never going to come off. Afebrile, not tachycardic, has normal respiratory rate. So the things that, and again, doing this for time perspective, so I agree with your first initial piece of, hey, let's stop thinking, let's stop fear of him. I agree 100%, but I would probably leave it there. Yes, we are growing gram-negative rods from a tracheoaspirate, but for simplicity purposes, if we think of a trach tube or what we get from a tracheostomy is maybe it's the tube of a pin, so it's a piece of plastic, and so we're just going to culture it and grow all sorts of everything all over it. So we have some cultures that are negative, but things that I want to show you are what I was taught as a young child is that the world is covered in a thin layer of fecal matter, and human beings are disgusting nonetheless. So I don't know what Jamboree is, but if anybody went, I'd love to know what your experience was like. But at the end of the day, there's poop everywhere. I think Shabir said he went to this, didn't you? Yeah, Shabir went. He said he was going to let everybody know about it. He's got pictures. But if we look at normal flora across the body and understand that there's organisms everywhere, there's microorganisms all over you, and depending on where you are and where you're located, your normal flora is going to change. The reason that hospital-acquired and ventilator-associated pneumonias happen with this whole 48-hour piece of being in the hospital or being on the ventilator is that typically after 48 hours of you being in the hospital, your normal flora changes to hospital-acquired flora. And so that's where that whole different association with the drugs comes into play with hospital-acquired pneumonia versus, say, community-acquired pneumonia. So I wouldn't treat this patient. I wouldn't give them anything. Their decubitus ulcer looks uninfected. Yes, their tracheoaspirate has a gram-negative rod in it, but their chest x-ray is clean. Their ventilator settings didn't get turned up to where they're requiring a ton of additional oxygen. They're overall maintaining everything. Their afebrile, their white count is 11.8, but again, maybe that's their normal white blood cell count. All of our normal values came from a set of healthy patients, and we took plus or minus 1 or 2 standard deviations on either side of the median, and that became the mean, what became our normal values. And so certainly you could have a patient who has a normal white blood cell count of say 11 or 12. So in my opinion, I think this would be normal flora. Dr. Glenn, what do you think?
Yeah, I have an expression based on an old movie called Field of Dreams. If you've ever seen that movie, it's actually a really good movie. But in it, Kevin Costner is trying to decide whether he's going to build this baseball field in the middle of nowhere. And he's talking to some guy, and the guy says, if you build it, they will come, right? Like they will come to the game. If you have a patient in a nursing home that's trach, or they have a Foley catheter, and it's there all the time, if you culture it, they will grow.
It will grow.
It will grow. So you've always got, anytime, and I try to really do this exercise a lot on rotation, I know Daniel does too, just because something grows in a culture does not mean you have to treat it. In fact, a lot of these patients, I would be shocked if this patient did not grow something, right? Because he's in a nursing home. So, he's going to grow, this is going here to question 2. I mean, he's got susceptibilities there, and Pseudomonas. I mean, I would be shocked, if you grow, and there's actually studies documenting this, if you put a Foley catheter in somebody, and it's there for 30 days, and you culture that urine, 100% of the time you will grow at least one organism. At least. Most of the time you'll get 2, 3, and a lot of times the lab will just come back and they tap out. They're done because they're like, there's so many organisms here, there's no way we can work this up. So always remember, treat the patient, not the number, not the culture. If you culture it in these patients, they will grow. If you remember that, and always go back to the clinical presentation of the patient.
Dr. Blaine,
Yes.
I found a PubMed article because I agreed that it was just colonization and not a current infection, but I was looking at scholarly articles to try to find the answer on whether or not to treat anyway. And I found out that said patients colonized with Pseudomonas were over 6 times more likely than patients not colonized to have a subsequent clinical culture indicating infection. So they said that for ICU patients, you do go ahead and treat anyway.
Yeah. So that's one study, and you know I don't know that study right offhand. First of all, I'm gonna say kudos to you for going and looking it up to try to find out that they are at higher risk, but I don't know who wrote that paper. If it was a critical care focus or an ID focus, that may determine part of why they were doing that. I will tell you that here's the problem we run into, and Daniel will chime in after me. These patients, this guy is like 40-something years old, right, Dr. Chastain?
Awesome. That's what I wanted to say because I was like, we're about to get cut off.
Still work?
We can hear you again.
I'm here, Daniel.
Okay.
So what I was saying was, here's what happens. This is a 40-something-year-old patient. What's going to happen is this person is going to come back multiple times, and every time you use an antibiotic, you're not going to eradicate the bug, and it's going to become resistant to that bug. I watched a 41-year-old patient die in my intensive care unit probably 8 years ago because I didn't have an antibiotic left to give him. So every time you use an antibiotic, you're likely going to lose it. And so the perspective on an article like that you talked about is that that's true. But again, if they're colonized, I'm not going to treat it. And our ICU intensivists won't treat it either unless something pushes them to do that, whether it's hypoxia, fever, hypotension. Dan, you agree with that?
I agree 100%. At the end of the day, it's, does your patient look clinically ill? And so in this situation, yes, for Pseudomonas, so I would go look at his ventilator settings and his oxygenation status overall, and is it getting any better? Is it getting any worse? If it's getting worse, then that's maybe a sign of hypoxia in this patient who can't tell you if he's hypoxic or if he's short of breath. So there's other things you have to look at outside of just what grows. If we were to take Q-tips and swab everybody in here, we're going to grow stuff. But nobody in here is critically ill. Nobody in, or at least I hope not. None of you look critically ill that I can see at least.
I don't know. They look a little delirious. So whoever, that article, that PubMed, if you could send me that link, I would actually like to look at it, and I'll get back to you on my thoughts on it. How about that?
Thank you.
Sure.
Any last minute burning questions?
I have
And I
a
appreciate
question.
y'all for staying over.
I know
Yes.
with skin and soft tissue infections, we talked about decolonization for MRSA. Is there anything that you can do to decolonize a patient with Pseudomonas? Like, would that be an option for this person to decrease their risk of getting clinical?
So I've never seen, I think that's certainly an excellent thought. I've never seen a way to decolonize someone with Pseudomonas. We don't have, say, a mupirocin for Pseudomonas, or the equivalent rather. But ultimately, especially in this patient, you're going to send them back to the nursing home that they came from. And because of the fact that they're on a ventilator, or a long-term ventilator, that increases their risk of pseudomonas regardless. So you would have to almost wipe it out of not only them, that patient, but also the nursing home, the long-term care facility that they're at as well. Dr. Bland, any different thoughts?
I got nothing to add. I wish there was something we could do, but not really anything out there yet.
And the other thing is that if you look at this patient's susceptibility results, he's already resistant to almost everything. And so our options are dwindling significantly and substantially on this patient in terms of what we would have left to treat him if he did develop an infection. Because more than likely what happened is he grew a normal Pseudomonas in the beginning, and then somebody decided, hey, we're going to treat it, let's give him a Levo or Cipro this time, let's give him Cefepime next time, let's give him Mirapenem. The same process happens, and then we shifted that organism, and it became resistant over time, and then it's just going to laugh at whatever antibiotic we throw at it later on down the road if he ever does get sick.
Just one.
Anybody else? I appreciate it. I appreciate it, Dr. Bland. That was fun.
It's fun. They said here in Savannah we should start like a podcast. We
Podcast?
could call it, yep, and I'll give her credit, the Daily Dose. That's pretty good.
That's snazzy. I was thinking it was going to be something like fecal matter everywhere.
I won't participate in any podcast with that name.
That's good stuff.
All right, remember National Penicillin Allergy Day? I sent an email to the class yesterday, so retweet, tweet. Okay, not really related to what I care about, but thanks for doing that. But if you can promote that, it'd be great. Dr. Chastain, will I see you Tuesday?
What is Tuesday?
San Francisco?
Oh, yes. I've got a long time until Tuesday.
Okay, same here.
See you. Have a good weekend.
Bye.